Well, welcome to the Trainers Bullpen, where trainers in the law enforcement space come to hear the experts talk about their work, experience, and research into human performance, particularly as it relates to the critical aspects of training motor learning and adaptive decision-making. The purpose of the Trainers Bullpen is to help bridge the gap between law enforcement training and the findings of academic research and current pedagogical best practices. Our desire at the Trainers Bullpen is to help advance law enforcement training, make research applied, and improve officer and public safety. The Trainers Bullpen is a production of Raptor Protection, and I'm Chris Butler, your host. And today it's my pleasure to welcome to the show Dr. William Bozeman. Dr. Bozeman is a national advocate of law enforcement use of less lethal weapons and self-aid buddy aid training in order to reduce or eliminate injuries and deaths whenever possible among police officers, suspects, and the public. He has conducted national studies on the use of Taser conducted electrical weapons, including the first large independent study of injuries from their use with funding from the National Institute of Justice. Dr. Bozeman's clinical and research interests include trauma resuscitation, cardiac arrest resuscitation, emergency medical services, and tactical medicine. Dr. Bozeman is a member of the National Tactical Officers Association and the International Association of Chiefs of Police Physicians section. He serves as a tactical physician for several law enforcement agencies and as an instructor and consultant for numerous law enforcement training courses. In addition, he has served as an EMS director on federal disaster medical assistance teams and as a NASA Space Shuttle support physician. He is one of the few emergency medicine doctors nationwide who is specially trained in trauma and critical care. Dr. Bozeman earned his medical degree from the Medical University of South Carolina, completed his residency at Johns Hopkins Hospital in Baltimore, and his fellowship training at the Shock Trauma Center in Baltimore. He has been a faculty member at the University of Florida and Wake Forest University. Dr. Bozeman, welcome to the Trainers Bullpen, sir, and thanks for making the time to join us today.
My pleasure. Thanks for having me.
Absolutely. So I read with interest fairly recently as I was reviewing the applied police briefings. And for our listeners and viewers, if you're not signed up for applied police briefings, you should do that. It's a free publication, and you can go to appliedpolicebriefings.com where you'll receive regular updates on very pertinent and important police-related research. So I recently read a briefing that was published there called Understanding Police Use of Force and Subject Injuries from Unarmed Physical Force to Firearms. And it was a summary of a previously reported or published article that was titled Injuries Associated with Police Use of Force in. So this is a particularly topical issue, the issue of police use of force, the perception of the public around police use of force, and because law enforcement officers, they understand that the public's perception typically is that police use of force is off the charts, it's out of control. And just to reinforce that, I recently just went online and I did a Google search around police use of force and excessive force. And here's just some brief headlines that came up. This one here, police use of force is out of control. There's another one recently by Carnegie Mellon, and the headline is U.S. police 3 times as likely to use force against left-wing protesters. There's one out of The Guardian that says U.S. police use force on 300,000 people a year, with numbers shockingly rising. And another Guardian news release, the good old Guardian, also from 2024, calls police use of force relentless violence. And if that's not enough, the Chicago Unbound article says this, that public concern about harmful policing and use of force is surging. So that's currently the narrative that law enforcement agencies often hear. But so Dr. Bozeman, I want to first hear from you about this study you undertook to actually understand police use of force and subject injuries. what was it that caused you and your fellow colleagues to even begin to look at this issue and want to do research on it?
Well, we were really interested initially, and my research into the epidemiology of use of force started in the, I guess, mid 2000s when there was a big uproar over tasers, the conducted electrical weapons, but everyone knows we call them tasers. Um, and there were some people who were injured or even died after taser use, and there was a big push to get tasers off the market. They're clearly killing people. And as an academic physician, researcher guy, I looked at all the reports and I said, wow, those are terrible tragedies, but are they really related to the taser? And is the taser something that's dangerous that we should take off the market? And I approached the United States NIJ, National Institute of Justice, with this crazy idea, saying that, I'm a doctor, I'm a researcher, but I also work with SWAT teams and law enforcement agencies. And I think we could look at the tasers and actually count every single time they're used and have a denominator, and then compare that to the numerator of how many people died or were injured. And they said, that's kind of a weird idea, and we're not sure you could actually do that, but we'll let you give it a shot. And we absolutely knocked it out of the park, honestly, with that first large taser study that demonstrated that no, people aren't dying left and right after taser use. As a matter of fact, they're rarely dying at all, and it's probably from other things. So that was a big success and an introduction into injury epidemiology for me. And we went back to the NIJ as sentiments like that were evolving and saying, you know what, we really need to look at the denominator, not just the numerator of how many times force was used, but in the context of how many arrests did they make where they didn't use force, and how many times did the police interact with people and not use force, and what's the actual truth out there, what's the reality say. And so we went to the NIJ with this proposal that we expanded from just tasers into all types of use of force. And they, given that we had pulled it off with the tasers, they said, yeah, that sounds like a good idea. Why don't we actually do some real research and look at what the truth is about this and get the real numbers, not the anecdotal evidence sorts of numbers.
Okay, great. And so what was your hope, your desired outcome? What were the research questions that you wanted to have answered as a result of this research?
Well, honestly, this is a simple, straightforward injury epidemiology study, and I keep using those words, but it's basically a counting study. We wanted to count the number of times someone had a significant injury. And by that, we meant moderate or severe injuries, not just a little scrape or strain or sprain, but a significant injury that might put them in the hospital or be life-threatening or require a surgery or something. And so we were very careful about building the research to identify significant injuries. And we were very careful about getting the denominator of how many times people were encountered or arrested. So we did all the appropriate research things, but what we really wanted to see was an apples to apples comparison using the same technique of how many people get a significant injury after each type of use of force. And that was the research question. What's the real number? What actually happens in the real world?
And one of the things that I know from my policing experience is that it can be, I think, challenging because often we confuse causation with correlation, right? And because you have a subject that officers, they attend a scene, they go to arrest an individual, they have an application of force, and there's the individual has experienced an injury of some sort or compromised medical condition that results in them being transported to the hospital. And I've seen previous research that has looked at injury outcomes that hasn't parsed apart was the transport to a medical facility or the medical intervention and the injury actually related to the use of force, or was it associated with other aspects of the incident, maybe even prior to the arrival of the officers? So how did you address that? How did you parse that apart in this analysis?
Well, that was one of the major findings of the study, and you're kind of skipping ahead to the end.
Oh,
But
okay. Well, I don't want to
no,
jump
that's
ahead.
okay. That's okay, because that was one of the major findings of the study, and I think that we may have been the first group to really tease that out. The way we did tease that out, and this is under the umbrella, well, we were very careful about how we did the research. Um, the way we teased it out was we had an expert physician at each site, and they had full access to the police records. They also had some access to medical records, depending on what the situation was. But the local police surgeon or police physician reviewed each and every one, and they were able to determine whether or not they were admitted to the hospital, and if so, why. And that's a legitimate part of the police inquiry into the use of force was, did our use of force cause an injury that made them be admitted or not? So that was generally present in all of these cases. And the expert physician reviewed it and said, well, they were admitted to the psychiatric hospital for schizophrenia. That was not related to the use of force. Or they were admitted for some other medical condition. That was not related to the use of force. And so we were able to very carefully do that. And that was one of our big successes with this study as well, was we were able to parse that out. And we found that, I'm doing this by memory, but roughly 3/4 of the people who did get admitted to the hospital were admitted for things entirely unrelated to the use of force. And so that's not a good surrogate. There are several studies out there
Yeah.
in the criminology literature that said, well, force was used and they had to go to the hospital. That must have been a major injury. And that turns out not to be the case at all. That's not a good surrogate.
Right. And I think that's super important for agency administrators to understand the significance of that, because you'll often pull your use of force data maybe from the agency, and you'll look at the reported transport to hospital or the reported injuries. But even the reported injuries, because, for example, I'm aware of many agencies that have mandatory subject behavior officer response or use of force reporting, where the officer will say, do a takedown on an individual. Maybe there's a struggle on the ground, get them in handcuffs, but the individual is injured. And so even in the agency's use of force report, there's a box that says, was the subject injured? Well, the officer will click yes, but again, that may be completely misleading, because there's no distinction between what was the causation of that injury. So I think what you were able to parse apart in this research is super important for administrators to understand. Can you tell us maybe a bit about the scope of this research? Like how many agencies were involved? How much data did you get?
Sure, absolutely. So this involved 3 agencies. One was my local agency in North Carolina, the Winston-Salem Police Department. One was in Mesa, Arizona, where they have a fantastic group out there that worked with us on use of force. And another was in Shreveport, Louisiana. We chose these very intentionally. We didn't want tiny little, 2-officer agencies that don't use much force. We also didn't want Los Angeles and New York or Chicago, as very large agencies in very violent cities. We chose these as mid-sized agencies in medium to largest towns where they see lots of activity. They do use force regularly. They have a mature reporting and surveillance system, and they represent the large majority of the United States.
Hmm.
So one of the limitations of our study is, well, this wasn't done in giant cities, and maybe something like this should be done in very large cities to see if it's the same or different. But we chose them very intentionally to represent the large majority of agencies across the United States and Canada as well.
Right, right. And how long was the data collection study?
This was done over a period of 3 years. Wait a minute, was it 2 or 3? Either 2 or 3 years.
Yeah.
Each of the agencies participated, I think, for 2 years, but they were staggered across 2 of the agencies. So temporally it was across 3 years, but each agency did 2 years of data.
Okay, and so at each one of these sites, you said there was a physician who evaluated. How did they evaluate the injuries? So you categorized the injuries. Maybe you can talk a little bit more about that. You mentioned severe, moderate. What were the definitions of the different categories of injuries, and then how did the physicians actually access? Did they access medical records? Did they evaluate the subject themselves, or how did that work?
Sure. So the injury stratification tool that we used was developed by our group and it's been used by ours and others in a number of different publications. It's kind of getting to be kind of a standard because prior to our research and others like it, people were categorized as either injured or uninjured. And that's not very helpful because how injured were they? Was it a
Mm,
little abrasion on the pinky or was it a gunshot to the chest and they died? Other studies looked at fatal or non-fatal, and non-fatal. There's lots of room there for non-fatal things. Were they disabled and in a wheelchair for the rest of their life, or was it a scraped up knee and they got a band-aid? So we developed this risk stratification tool, and it's really a common sense sort of thing, but there are lots of medical nuances to it, and that's why we had an experienced board certified uh, physician or surgeon reviewing all of these. But fundamentally, it's very easy. It's either mild or moderate or severe. Mild injuries were mild. They didn't require admission to the hospital. They were treated as an outpatient. They had no particular expectation of long-term disability. So things like a sprained ankle, a contusion, an abrasion from fighting with the police, those would be categorized as mild. You expect people to make a full recovery and they don't need to be admitted to the hospital. A moderate injury, on the other hand, was something that needed to be admitted to the hospital and or you had a significant risk of long-term disability. Things like a broken leg or a broken arm that might need to be admitted or have some long-term disability. Things like a gunshot wound to the chest that made you have air inside the chest called a pneumothorax. That's relatively, it's only a moderate injury. I don't also say mild, but it's a moderate injury because we put a chest tube in. You sit in the hospital for a couple of days. The chest tube comes out, the lung heals itself, and you go home with no particular expectation of disability. I've placed hundreds and hundreds of chest tubes in patients with penetrating trauma of a variety of types, and they all tend to do very, very well. Of course, there are exceptions, and we'll get to those because those would be severe. Um, Severe injuries would be, yes, they require treatment in the hospital, but there was a real risk of or threat to life, or they had to have a life-saving surgery. That same gunshot that did a small injury to the lung that healed in a couple of days, if that gunshot was to the spleen and they had to do a life-saving surgery to take out the spleen and stop the bleeding, that would be a severe injury. So
okay,
mild, moderate, and severe
all right.
as as judged by an expert physician who knows about these things. And
Okay,
that was
right.
our criteria.
And they looked at medical records, or how did they, where did they get the data to evaluate the
So the
injuries?
data primarily and almost entirely came from police records. This was a prospective data collection, but it was really looking at retrospectively at the police records. So every use of force investigation, as you know from living in this world, every use of force has an investigation and a review and goes into a database. These agencies were very particular about how they collected their data. There's a mandatory investigation and mandatory reporting to our study, and it included the injuries that were identified by the police and whether or not they were admitted to the hospital, all the things like that. Now, there is a subset of people with typically with severe, life-threatening, or even a fatal outcome, where the police investigation goes even deeper, and there is a provision within the United States HIPAA laws that an official police investigation can access limited medical records. And that was done in a few of the cases. So they actually had medical records in a few cases, but the large majority was simply reviewing the police use of force investigation that carefully documented what the injuries were and what happened to them.
Okay, now I can almost hear the objectors raising their hand and saying,
Yes.
well, wait a minute. So you were relying upon the police who used the force, who documented the force. You're relying upon the accuracy and validity of their reporting. And so I can see some people raising a concern about, well, how did you audit? Was there any auditing at all, or check and balance at any level to go, did you compare any hospital medical records against any of the police reporting to go, yes, that you were satisfied, you had a high confidence interval that the accuracy or the police reports actually reflected an accurate account of what happened?
That is a great question. There are multiple layers of accountability, but those tend to be within the police agency itself. We were not able, because of there are kind of some firewalls involved here, and the reason some of this research is unique is we've been able to get around some of those firewalls and combine medical expertise with police expertise and use of force uh, investigations. So, because of those firewalls, we did not do independent uh, validation of each and every hospital admission.
Right. Okay. Um, so what were you said you were looking at both frequency of use of force compared to like police public interactions, looking at frequency of use of force compared to arrests as well. And I think that's super important because those are, one would expect that the frequency of use of force compared to police public interactions would be extremely small. But it just kind of, I think a lot of people almost intuitively would think, yeah, but when you go to arrest somebody, you go to put handcuffs on them, that's when we see a lot of use of force, is when officers conduct arrests. So I found that super interesting in your research, because you looked at both sides of that, police public interactions and use of force and arrests. So talk to us about the frequency of that. How often are our cops using force?
So the truth is that police do not use force very often, and that has been consistent across study after study after study in both the United States and in Canada. And it is intuitive that the police going up and interacting with someone generally doesn't involve use of force. They may be on community patrol and saying hello to the neighbors at the grocery store. You wouldn't expect all of those to result in a use of force, despite some people's perceptions of this. If a
Right.
police officer comes up, they think they're going to be beat up or something. That's not the case. I hope that's not the case. It's certainly not statistically the case. Um, and so, as you might expect, the police interacting with someone rarely leads to use of force. Um, However, the police having to arrest someone, you can imagine, okay, put your hands behind your back, and they go click, click with the handcuffs, and no force was involved. But a lot of people perceive that arresting someone is going to involve some physical force. And what we found was that that is not the case, and that actually use of force was in less than 1 in 1,000 police public interactions. And even among those who were arrested, it was less than 1 in 100. So 99% of the arrests were simply informing the subject they were under arrest and putting them on the handcuffs. And that honestly is a bit surprising, even to me as a researcher who works with law enforcement. That is very rare. Now, the cases that force is used in, well, that's what we looked at here, but it was remarkably rare. It was less than 1 in 120.
Right. So, yeah, a couple of questions arise in my mind out of that. So, what was the threshold for reporting use of force? So, for example, if an officer was arresting somebody and used a wrist lock or a come along technique or something like that, was that a reportable use of force, or what was the threshold of force where it was started to be reported?
That is a fantastic question. And the answer is it depends on each of the agencies. They have their own thresholds for reporting. And lower level force, like it's kind of grouped into the soft hands category of a wrist lock or a pressure point or a come along sort of hold. Um, some agencies don't fully report that as use of force. And that's where it does get a little bit fuzzy at that very low end of the use of force. you can make an argument, and I'm sure you're fully aware of this, that the use of force continuum begins simply with the officer being present and then verbal commands. Anyone who's been driving down the highway just a little bit quick and sees the police officer behind them, that presence of the police officer will probably modify your behavior. And most people will say, oh my goodness, there's a police officer behind me, I better check my speed. So that is a legitimate thing. But at what point do they have to file a use of force report? That's where it does get a little bit fuzzy at the soft hands. All of the agencies, I understand, I'm very confident that as you reach the next higher level of hard hands, where you're striking someone with a closed fist or an elbow or a knee or a foot, all of the agencies, I'm sure, were capturing those with a high degree of fidelity.
Right. And I think it's fair to say, and you can confirm or say I'm inaccurate based on your research here, but those lower thresholds of force, the soft empty hand techniques, the wrist locks, the come alongs, the arm bars, would it be accurate to say it is extremely unlikely that there would be any kind of injury, let alone mild, moderate, or severe? But I mean, it's just in my 34 years of law enforcement, you hardly ever experienced a subject obtaining an injury at those lower levels of force.
That is the intuitive thing that most people would think, but that is one of the surprising findings in our study, was that even with lower level empty-handed techniques, there were a number of significant, either moderate or severe injuries. And that was a little bit surprising because it's not very intuitive. On the other hand, if you imagine you're pushing someone along or escorting them over, that's not much force, but then they trip and fall down, they bonk their head. They could get a significant injury from that. We did find several of the significant injuries were related to either hard hands or soft hands.
Okay, so let's say if an officer has arrested somebody and put them in handcuffs and they're escorting them, say, to their vehicle at the curb or something like that, if the subject in handcuffs tripped and fell and struck their head on the sidewalk, would that resulting injury then, would that be reported as a use of force event, that injury? Or
that's where the reporting gets to be so important. And that's why having the doctors have full access to all of the different reports, all the different accounts. If it simply was a trip and fall, perhaps not. But if they tripped and fell because they were being manipulated or taken down by the officer, that would absolutely be related to the use of force.
Right.
So that's
right.
where the doctors doing the review, having the full access, became very important.
Sure. Right. Absolutely. Absolutely. So going back to your frequency again, so you said, I believe you said that when officers completed arrests, the frequency of use of force was around 1% or just less than 1% or something
Just
like
under
that.
1%. I think it was 0.8.
Okay. And was that surprising to you and your colleagues? Because when you think about it, and maybe we can talk about the number of subjects that were under the influence of alcohol and or drugs and stuff like that as well, or were experiencing a mental illness or something like that. But you have police officers taking individuals into custody, making arrests, and some of these are the most difficult individuals to deal with, highly intoxicated by drugs and or alcohol, under mental health issues. And yet, even with throwing all of those into the pot of the arrests, we still see they're able to complete an arrest on these individuals without the use of force over 99% of the time. Was that surprising to you?
That was quite surprising to me on an intuitive level. And then the researcher part of me looked at all those Canadian studies that said it's about the same number. It's about just under 1%. And we had all said, well, it's just those Canadians are so nice.
We are.
You are. But to find that redocumented and confirmed in mid-sized cities in the United States was a bit surprising. Now, one of the potential artifacts of that, or aspects to that, is what you mentioned just a few minutes ago of, well, at what level does it really become a use of force? How much force of twisting their arm as they were being put into cuffs? At what level does that get reported as, a pressure point control tactic or something? I'm confident that there were plenty of arm twists that happened that did not get reported as use of force. And that's not to say that that's good or bad. That's just acknowledging the limitations of doing research in the real world.
Right.
And
Right.
again, going to our focus was not on those minor injuries that might be related to lower levels of force. Our focus of the research very intentionally was on the significant, the moderate or severe injuries that are so important from both a medical standpoint as a doctor, but also from a liability and a medical legal standpoint for the agency and a policy standpoint for the agency.
Right. Okay, great. So let's talk about the level of injury then. We've spoken about the frequency. Can you maybe break apart what did you see as far as the severity of subject injuries? How did that land?
Well, overall, there were, let's see, just over 1 million calls for service, 114,000 criminal arrests, and 893, almost 900 use of force incidents that involved 914 suspects. So we're talking about almost 900 incidents of use of force and just over 900 suspects. So that's the group that we're talking about.
Okay.
Of all of those, 98% of them, even after some use of force, 98% had either no injuries or mild injuries only. That is staggering. The fact that police don't use force very much, and even when they do, 98% of the suspects don't have a significant injury. That is just staggering.
Well, that's certainly counter narrative.
Counter narrative, absolutely. So that was kind of the big headlight, one of the several findings that we had that really say the real world is not what's being described to a lot of people. The actual reality is very, very different. Now, the 2% that did have a significant injury, that's really a very important 2%, isn't it? And that's the group that we really wanted to look at.
Right.
So we found that in general, when the force was used, it was either unarmed physical force or tasers. By far and away, those are the most common force modalities that are used. Other things like chemical spray, canines, impact weapons, kinetic impact munitions, and of course firearms, they are rarely used in these situations, which is good news from an overall societal standpoint.
Sure. Right.
Right.
Right. Now,
Yeah.
with those frequencies though, and just I think so our listeners don't um, couple two things together, the frequency of taser use does not imply there's no relationship between that and the frequency or severity of injuries, right? Because I think you're going to why don't you talk to us then about like these different use of force modalities, particularly, the intermediate weapons, the conducted energy weapons, OC spray, baton, physical control harder techniques that you talked about, the striking, elbows, knee strikes, fisted strikes. Is there a scale of how do we understand which of those are likely to cause more concerning injuries to subjects?
So we did exactly that. We broke them down. Overall, there were 16 out of these over 900 people who had force used. Only 16 of them had a moderate or severe injury. And as you might expect, the most common thing that will cause a significant injury is a firearm. If you shoot someone with a bullet,
Yep.
they are
Sure.
most likely to be seriously injured or to die.
Sure. Yeah.
There was one fatality in the group due to firearm use. Interestingly, there was a second fatality that presented as a behavioral complaint and an agitated combative individual who died in police custody. Had nothing to do with the police use of force. It was a drug overdose in someone with a heart condition. And that's probably a whole nother podcast to talk about those excited delirium or hyperactive delirium with severe agitation.
Yeah,
Folks.
absolutely. I think that does need to be a separate podcast. Not to discourage talking about it here because I think it's super important. But
Right.
one of the most common questions I get when I do the training, and someone just phoned me on this from an agency a couple of days ago, going, "What do we do with all of our policy and training that has the words excited delirium in it?" So what's the recommendations? What's the current research? So this is a huge issue, and I think it's worthy of having that conversation in a separate podcast. But it as a nutshell or an elevator story, is there anything that you would just say if you had the ear to trainers or agency administrators who are responsible for policy and training content? What do they do with this whole excited delirium issue?
I think the most important thing is to realize that there is an entity out there that presents with some behavioral cues and is a marker for someone who might suddenly unexpectedly die. We need to continue to recognize that entity, regardless of what you call it. Continue to treat these people as a medical emergency and continue to get EMS and medical providers involved so we can save lives. I think the whole
Okay.
discussion on what the name should be is a little bit silly. The practicality in the modern world is they may want to go and change the name in their policies. But the most important thing is we're all trying to help people. We're all trying to save lives. And
Right.
there is something out there that is a marker for someone who might unexpectedly die.
For sure. Absolutely. So if an agency had historically had, we'll say, the gold standard of an excited delirium tactical approach, which was, we know what that is. If you can contain, delay the application of force if possible, get medics on scene, work with medics beforehand to have a restraint protocol and use the appropriate interventions, get them into medical care as quickly as all of that. If they had the gold standard of excited delirium protocols, this is a question I get. Do we just take excited delirium out and put hyperagitation, or I forget the term, hyperagitation with delirium or something in, or is there an actual change in protocol that's now directed as a result of this name change?
There's no change in protocol. The newer publications have reinforced that yes, there is this entity, this pattern that you can recognize, that is a marker for something that might kill up to 16% of the people who have it. And we should all take it seriously and treat it as a medical emergency and do everything we can to help these people. And so
Perfect.
if you have the gold standard program, keep doing it. You can call it whatever you want to.
Okay.
Part of me says, what's wrong with the old name? I don't really agree that is a problem. Part of me says names evolve, and if we want to call it something different, that's fine.
Sure. Right. And especially if it's helpful to uncouple the name from all of the accusatory language around excessive use of force, and as an
Focus
excuse
on
for
helping
that.
people and saving
Exactly.
lives rather than on silly discussions about nomenclature.
Right. Good. Thank you for that. Great. Sorry for that distraction. Little side journey, but that's an important discussion. So you were looking then, okay, so all of these different use of force modalities, what was the scale of, aside from firearms, for sure, you mentioned that obviously it's going to result in severe injuries.
Yep.
But
most likely to give you a significant injury that would put you in the hospital or be a threat to life was a canine. In general, if a canine was used, there was an average of between 1 and 2 bites applied into separate body parts. And several people had canine bites to either upper or lower extremities and had to be admitted to the hospital for management of the wounds, sometimes some orthopedic injuries. That was the second most likely to cause some sort of significant injury.
Okay, good. Let me just pause you right there because I think that's an important part as well, because I don't know specifically what it might be like in the United States, but in Canada, our use of force frameworks, whether that's the national use of force framework or the RCMP's IMIM or other provincial models, will typically put canine in the same band as intermediate weapons. So, for example, a baton, a taser, in that same sort of category as intermediate weapons. But what I'm seeing with this research and with some other data that I've pulled around canine is canine deployments actually have a very particular use of force injury profile that's completely different than the other intermediate weapons in that category. So I wonder if it's worth agencies having a conversation around where does canine fit then if we understand what the injury severity is likely going to be from the research from a canine contact. Um, does canine then have a different place in the use of force continuum?
I think you're right. I think it's time to start having a conversation about that. However, I think it's also important to realize that the numbers in our study, even though this is a large study with over 900 people with use of force and a million police public interactions, we're still talking about relatively small numbers.
Right.
It was only about 10% of the canine uses that had a significance. So that means 90% didn't, on the one hand. But recognizing there's approximately a 10% chance, give or take with confidence intervals and all those researchy things, but approximately 1 in 10 is going to have a significant injury. It's fine to have a conversation about that and maybe peel that off into a different category because as we're about to cover, a lot of the other intermediate force options have a lot less than 10% likelihood of significant injury.
Okay. So yeah, let's carry on then. What comes
Yeah.
next after canine?
So interestingly, physical force, either hard hands or soft hands, about equally distributed, were responsible for as many, let's see, you have to take into account how often they were used, of course, but physical force was used very, very often and resulted
Mm-hmm.
in 6 significant injuries in this study. Canines were not used very often, but resulted in 5 significant injuries. So it's not very common, but it is the next most common thing would be physical force and about evenly distributed between hard and soft hands.
Now, were you able at all to, and maybe you didn't dive this deep or weren't able to into the data, but did you look at the subcomponents of that physical force? So, for example, a dynamic takedown. Did you look at the profile of takedowns? Did you look at fisted strikes versus elbow strikes and knee strikes and injury outcomes, or was it just more of a broad category?
In this study, we were only able to do it in terms of broad categories.
Okay.
That would be a great next step research to do. If you had a particularly high functioning agency with large numbers, lots of officers, lots of land territory, and an absolutely fantastic training cadre and use of force review group. Oh, I don't know, RCMP listening?
We'll make sure
An agency like that.
Dr. Baldwin get
Absolutely.
listens to this. Yeah.
Yes, they have been a fantastic group to work with some of our research, not this particular one,
Yeah, they
but
sure are.
I've been extremely impressed with that agency or another one like it would be able to go all the way down into that granular level of what kind of takedown was done, what exactly was involved in this takedown or in this use of force. That would be a wonderful study to do.
Right, right. Well, of course, the reality is what I've come to realize reading great research like this is the usually when you get to the limitations section, what becomes clear is this research paper has uncovered multiple avenues for other fantastic research that needs to be done. So that's, I
Exactly.
think, another good sign of great research that it does that. So, okay, so we have physical control, soft and hard came next in sort of that continuum of injury outcome, and then what was after that?
Let's see. There was one case of a chase or flight that I believe it was a foot chase, um, and someone fell and broke their arm and had to be admitted to the hospital. That was a moderate injury, and that was due to a foot chase. Um, what we found that was very interesting, having done taser related studies, yeah, you can and do get significant injuries from tasers, but they're extremely unlikely. Just off the top of my head, I think 99.7% of people do not have a significant injury after a taser use. But there were just over 500 uses of a taser in this study, in this group of use of force incidents, and there were no significant injuries. And that puts the taser at the end of the list in terms of having injuries. We observed none, but the confidence interval around that, which is the statistical method that we use to describe how sure are we about this number. The confidence interval is very narrow, so it's going to be close to zero, and that corresponds with our previous studies that say 99.7% don't, so 0.3% might. Those are essentially statistically the same number. So we demonstrated again that using an apples to apples comparison, a taser was the least likely to cause injury. Now, we also observed no specific injuries with impact weapons, batons, or OC spray, or kinetic impact munitions, the rubber bullets or beanbags that are sometimes used. But because they were rarely used, those confidence intervals are very wide. So the true number, the reality number, may be anywhere in that interval. So we can't say that they're just as safe as a taser, but given the large numbers of tasers, we can say the taser is extremely safe.
Okay. Yeah. So a couple comments or questions on the taser. So you said approximately 500 uses of the conducted energy weapon, which is a great number. But did you pull apart because some agencies might describe a taser deployment or a taser use as an officer challenged with a taser, pulled the taser out and issued a taser challenge. Others might be armed the taser and put the laser on the subject. That's a taser use. And drive stun versus probe deployments. Did that break out? Was there any difference?
We did break that out, because we have experience doing taser studies. We were very specific that a warning arc or simply clearing it and putting the laser pointer on someone did not count as a taser deployment. That would be a taser display. They were only counted in this study if a discharge was directed toward the subject.
Okay.
And if you notice there, that's a careful wording, because just because you fired a taser at someone and one of the probes hit them doesn't mean any electricity went through them.
Right.
So,
but it's still
discharging it towards the individual. And we did break out whether it was in probe mode or drive stun mode. And we counted the number of cycles and all those things.
Okay, perfect. And so just again, to summarize, that taser had basically, if we can say, and I almost hate to use this word safe, because, no violent encounter between a subject and a police officer is safe. There's a potential for injury for one or both of those parties. But statistically, with the taser use, it was a device or an intervention that resulted in really the safest outcome, the lowest amount of injuries for subject. Did I summarize that correctly?
That's exactly it. I'm looking down at my paper right now to see the wording we use. We said CEW, conducted electrical weapon or taser. CEW use was the force modality least likely to result in significant injury. And that's another one of those big flag studies or findings of, wow, that's very different from what a lot of people have been led to understand.
Right.
But that's the reality based on good quality scientific study.
Well, absolutely. And, somebody once said to me that a lie can travel all the way around the world before the truth has had a chance to put its shoes on. So,
Exactly.
it takes time to do great research like this. But by then the popular narrative is out and people will believe what they'll believe. But it's great to have research that dispels those misperceptions for sure. You mentioned about baton. You said that there was so little baton use that the confidence interval was not high. Do you recall how many baton uses there were?
I happen to have it in front of me. Let me see.
Okay.
There were 9 impact weapon uses, and we were broad enough. It could be an expandable baton, it could be a rigid baton, or it could be a weapon of opportunity using your radio as an impact weapon, for example.
Okay.
So any
Okay.
impact weapon, but most commonly batons, there were only 9 uses. And so that is 0.6% of our uses of force.
0.6%.
Of those, we didn't see any significant injuries, but the confidence interval is very broad on that.
Yeah.
It may be as
And the
much as,
reason,
just
sorry,
eyeballing
go.
it, it could be
Yeah.
as little as 0 or as much as 35%.
Yeah.
So
It's
with only 9
interesting.
uses, you can't make a statistical determination like that.
No, but it should raise the question, and this is a question that actually is being raised by some progressive law enforcement trainers that I have worked with, is when we look at the incredible infrequency of baton deployment, is it time that law enforcement agencies, again, when we talk about having brave conversations, are we at the point where we should be having a conversation about, is this, if it's a tool that is not being used hardly at all, and we spend a considerable amount of time in training, and so the expense of acquiring them, the training of them, the recertification of baton use, and is it time, Doc, do you think we should start having evidence-led conversations about the equipment we carry, and is it time to discuss maybe retiring the traditional police baton? I don't know.
Yeah.
I'm not an anti or pro baton guy. I'm an ASP baton instructor, and um, but I
So
think the
from
research is pretty telling.
Yeah. So you're absolutely right. It's not used very often. And there's a great deal of training time and energy expended on this particular tool. Um, as a researcher in general, I would say, yes, it's absolutely time to have conversations like that. And you could have a similar conversation about any of the tools or techniques that are available. Um, however, I would throw in there, that's me as a knowledgeable person who knows some about this research. That is not me as a medical doctor saying that this is an unsafe thing.
Right.
And that's the authority that I have as a physician. I'm very careful with. And just because I may agree or disagree with something based on the data shouldn't be misinterpreted as, well, the doctor said no, therefore it's medically unsafe. That's not
Right.
what I'm saying at all.
Right.
As a matter of fact, we found no injuries. But
Right.
yes, could we have a conversation like that based on what we know about the epidemiology of this? Absolutely. I think that would be a good conversation to have. Maybe a
For
tough one,
sure.
but good.
Yeah. Yeah, it would. There's a lot of police officers who love that baton.
Yeah.
Yeah. Well, so one of the things I noticed, so in this, I was looking through the paper and looking at all of the different use of force applications, and I see that vascular neck restraints were not included. And was that because the three agencies that you mentioned, they do not use the VNR, or what's the status with that?
That's exactly why. We would have liked to include VNR in this because we wanted to do an apples to apples sort of comparison. However, the three agencies did not authorize use of VNR. Only, and I'm stretching here, but correct me if I'm wrong, but it's only about a third of police agencies that are authorizing the use of VNR in the United States, I believe.
Yes, I
Uh,
think that's about right. 30%, 30 some
yeah,
percent.
yeah. So the three agencies that participated in this study did not authorize VNR, and that's too bad. And that's why we went ahead and recruited some other agencies that did and did essentially the same study with some other agencies. And we recently published a very similar study looking at the vascular neck restraint. And I think you could probably compare it to the data in this study pretty well.
Okay. All right. So, well, why don't we do that? We have about 10 or so minutes left here. And I have a copy, just so happened to have a copy of that
You just so
VNR
happen to have one. That's
paper
amazing.
in front of me
You,
that
you are amazing.
that you and your colleagues published, and I'll make sure that a copy of this paper is also appended to the show notes and encourage trainers and administrators to look at this. It's titled "The Safety of Vascular Neck Restraint Applied by Law Enforcement Officers," published in the Journal of Forensic and Legal Medicine in 2022. All right, so Doc, take it away. You said you could basically take the VNR data, the safety data that you looked at here, and lay it over top of this study, the use of force and injury study. So why don't you tell us where would that fit based on the
Sure,
research?
sure. So we we did a similar, but not exactly the same sort of study. This had to be because of the number of uses each year of the VNR. Um, there were a moderate number of uses each year. So we included a decade-long period of also a retrospective review of police records looking at use of force investigations. So very similar, but a longer period. Um, and we looked at, again, at three agencies, two in the US and one in Canada. RCMP in Canada did a phenomenal job. I'm quite impressed with them. San Diego and the North Carolina Highway Patrol.
Okay.
So three much larger agencies than the previous study. So that is a slight difference. But we looked at a 10-year period from 2010 to 2020, I think. So the one agency that went above and beyond did those inclusively. So it was actually 11 years.
Hmm.
And we looked at the number of VNR uses and did a very similar physician-led review of risk stratification of any injuries, stratified them as mild, moderate, severe, counted the moderate or severe as significant. And we then did an additional thing because the opportunity presented itself. And that is, we looked at the application of the vascular neck restraint. I believe it's carotid control technique for RCMP. So I use those
Carotid, correct.
interchangeably.
Yes. Yeah.
So forgive me if the wording's a little bit different in the different agencies. In my mind, it's VNR or LVNR for lateral vascular neck restraint. But because of what you just mentioned with the baton, because you have to spend a great deal of time training people in this and retraining them and recertifying them and doing annual in-services, we realized that the officers themselves in a training setting were applying and having the VNR applied to them over and over and over. So we also had the agencies report to us any injuries that occurred during the VNR training among their officers. And I'm gonna have to look. We had a total of 944 field VNRs against criminal suspects. So again, over 900 uses in the real world with a real suspect really resisting. It's a very real fight. These are very dangerous situations. And to get over 900 of these is a really remarkable thing.
Right. Absolutely.
So, and all three agencies, again, did a fantastic job of collecting the data and allowing their doctors to review it and getting it to us. Remarkably, though, we also had over 18,000 training applications. And in a training setting, you're not sure if they're going to apply full pressure or not. And it depends on the agency and the trainer and the program and all. But we were very confident that there were a large number of vascular neck restraints applied in over 18,000 trainees. So to begin with, we looked at how many fatalities there were. In the training setting, there were no fatalities. In the real world setting, where you have actual criminal suspects doing real fights with real officers, we saw 0 fatalities. And that was quite surprising given what a lot of people understand about this. Knowing about the physiology of this and the previous research and all, it wasn't as surprising to me, but a lot of people are really shocked to hear that the VNR, the vascular neck restraint, that applies pressure to the carotid arteries and makes someone briefly lose consciousness, doesn't kill people. And that's a really remarkable finding. We did have some injuries reported. I'm trying to remember the numbers, so forgive me if I take just a moment. So in the real world subjects, there were 12 reported injuries, and they were all mild. There were no moderate or severe injuries. No one had to be admitted to the hospital
Hmm.
after a vascular neck restraint.
That's
And
incredible out of
isn't that
all of
amazing?
those applications.
Yeah.
Yeah.
And in the
Yeah.
training, the over 18,000 training applications, there were 76 injuries. All of those were mild. And also, interestingly, uh, only about half of them related to anything regarding the neck at all, the pressure that's applied to the neck by the VNR. Uh, about half were due to the grappling component. You can't really separate out, as a trainer, you
Right.
cannot separate out the compression aspect of the vascular neck restraint from the grappling and the subject control and apprehension technique aspect of it.
Correct.
So of
Exactly.
the injuries that we saw a broken nose, we saw a broken finger, we saw a strained knee, we saw someone with a sore neck, uh, all of those things. And again, the doctor reviewing it had to decide, well, the knee strain was probably not due to the neck manipulation. The finger, I can't remember off the top of my head whether they decided that was related to the neck manipulation or not. Uh, so they had to make a judgment, and we did tease that out. And it was roughly half and half, if I remember correctly.
Okay. So going back to the previous scale, then, so if we think of canine physical control, soft and hard, we have baton, we have OC spray, we have taser, um, going from most frequent application of force and injury to lowest, with taser at the lowest. Where would you then, based on the VNR research, where would you slot the VNR into that framework? Like
The
where should
VNR, yeah, the VNR would sit right beside the taser.
right beside the
And
taser? Okay.
yeah, right beside the taser. And the reason is we have a large number of uses. So we have a very small confidence interval. We're very confident that this is the reality number in the real world. And we had 0 fatalities and 0 significant injuries. So
Perfect.
it's right at the bottom of the scale where these techniques or tools are least likely to cause a significant injury to the suspect.
Great. And once again, I would really encourage our listeners to read both of these papers, Injuries Associated with Police Use of Force and Safety of Vascular Neck Restraint Applied by Law Enforcement Officers. Both of those papers will be made available to you in the show notes at the Trainers Bullpen. But I just want to read this. One of the concluding paragraphs out of your VNR paper says there have been recent calls to ban all neck manipulation techniques by law enforcement officers due to safety concerns. The absence of fatalities or significant injuries demonstrated by our data, combined with a high success rate and lower overall subject injury rate compared to other force options reported in another recent study, suggest that these bans may be unnecessary when the VNR technique is executed by well-trained law enforcement officers. Further, banning a safe and effective force option may be counterproductive by forcing law enforcement officers to utilize other force options with higher risks of injuries. So really, I mean, that should be a super important paragraph for law enforcement administrators, chiefs, policymakers. But I want to give you the final word, Doc. We've been going for an hour. So I want you, if you had the ear of a senior police executive and you were talking to them about these two papers and your research and the findings, what would be the important implications or takeaways that you would want them to have from this research?
I think the most important thing that I would try to impart to them is not to listen to emotional sorts of things. Be sure to be grounded in reality and look to the high quality research that reflects what the real world risks are and what the real world performance of these tools and techniques is. As you mentioned, the VNR is 92% effective in terms of getting someone in custody, and it does it safely. That's what you should be grounded in, and high quality, real world research from people who understand both the police aspect and the medical aspect, um, and do the best thing for your citizens and the people in your jurisdiction. as well as your officers.
Perfect. I can't imagine a better conclusion to this podcast. We've been speaking with Dr. Bill Bozeman. Doc, thanks for making the time once again. Sure appreciate you and the work you're doing to help advance law enforcement training and improve public and officer safety.
Well, my pleasure. Thank you so much for having me, and thank you for all that you've done as well.
Well, we hope that you've enjoyed this episode of the Trainers Bullpen. And as always, our encouragement to you is that you would reflect deeply about the critical aspects of this interview and how you can apply the principles that you heard to advance your training and make your students more effective and adaptive performers in the real world. As a reminder, all of the research papers, as well as the other links, are available to you over at the Trainers Bullpen website at trainersbullpen.com. Thank you for your dedication to advancing officer and public safety.